This is the fourth session, and we have a distinguished speaker, Dr. Naveen from JIPMER. Naveen has completed his MBBS from AIMS Rishikesh, and he has completed his post-graduation in MD Emergency Medicine from Amrita Kochi. And now he's currently working as a senior resident in JIPMER Institute. Thank you, Naveen, for joining us, and over to Naveen. Hope everyone have a lovely lecture today.
Okay, thank you very much for your introduction. So today I will be talking about the topic opioids and NSAIDs. And I am going to take this lesson in view of preparing for the examination per se and also understanding the toxicology about these toxins, which is opioids and NSAIDs. So yeah, let's start ahead with the topic. So let's talk about the opioids, which is a clinical overview. We'll talk about the comprehensive and exam-oriented review of the opioid pharmacology, the toxicology, intoxication, and management. So first of all, what are the opioids? Basically, opioids are all the compounds related to opium that possess some analgesic and sedative properties. Opioids specifically refer to the naturally occurring alkaloids, which is the morphine and the codeine. These are derived from the opium poppy plant, with scientific name is Papaver somniferum. So you need to understand the opioids are the compounds which have both analgesia and sedative properties. Apart from that, the term narcotic is used predominantly by law enforcement for the controlled substance abuse, which has abuse potential. So we should not be using the word narcotic in terms of medical practice. Next, let's talk about the opioid receptors and pharmacology. So regarding the opioid modulation, it acts across the CNS, peripheral nervous system, and GI tract. The way it acts is via the G protein coupled transmembrane receptors. As you all know, there are three receptors on which the opioid compounds can act. Each receptor has its own distinct clinical profile. The three receptors are mu, kappa, and delta. So I'll be trying to orient you with each specific receptor function. The mu receptor is one which can cause potent analgesia, sedation, euphoria, and also causes the eye signs such as miosis and importantly the respiratory depression. It also causes the reduced GI motility and cough suppression. Whereas kappa causes some kind of weaker analgesia and sedation and also causes the miosis. It decreases the intestinal motility, and more importantly, it is the one responsible for your hallucinations and dysphoria. Whereas delta has some analgesia and antidepressant effect. The key exam point here you need to remember is all currently available opioid agonists will always have a mu receptor activity. Therefore, all the mu receptor functions will be produced. And more importantly, you need to understand that there will be some degree of respiratory depression with all the available opioid agonists. Next, the opioid category and types. So we have three types of opioid categories. That is first, naturally occurring, that is the opiates, and then semi-synthetic and fully synthetic. The naturally occurring, as we discussed, from the which are directly extracted from Papaver somniferum, both the morphine and the codeine. Whereas semi-synthetic are the ones which are the chemical modifications of this naturally occurring. So the example are, so the, sorry. So the examples of the semi-synthetic are oxycodone, hydromorphone, and heroin. These are actually the chemical modifications of this naturally occurring. Whereas the fully synthetic are structurally distinct, and these are made in laboratories like fentanyl, methadone, tramadol, and meperidine. You need to understand that fully agonist means which act at all the opioid receptors like the mu, kappa, and delta. So the examples of the full agonists are morphine and hydromorphine, whereas others all fit into the category of mixed agonists and antagonists. So this is the category where there will be partial agonist and different types like pentagon withdrawal profiles. absorption and formulation. All the opioids which have been described, all the opioids which are available, they have this oral. When we have taken in oral, it takes 30 to 60 minutes for the absorption. They'll reach the peak plasma levels within this 30 to 60 minutes. And if you take something like controlled release, it will take around 90 minutes to enter the blood plasma levels. And a few other opioids like long acting, that is methadone, they'll have the similar peak time reaching within 30 to 60 minutes, but they'll have extended clinical effect and half-life. All the opioids have to undergo first pass hepatic metabolism. So post the hepatic metabolism, they'll have an oral bioavailability of 10 to 80%. That's the reason parenteral doses are more potent with the equivalent amounts. Next, the following are the few opioids which have good oral bioavailability, which are codeine, oxycodone, methadone, hydromorphone, and tapentadol. Next, we'll talk about the metabolisms. Regarding the hepatic metabolism, codeine, meperidine, methadone, morphine, and this oxycodone are primarily hepatically metabolized. So any drugs which are other than, which are also being hepatic metabolism, they will have this like antiretrovirals will cause antiretrovirals will cause the increased methadone metabolism, and that's why they'll cause decreased plasma levels. Hence, they'll be pushing the patient into withdrawal state. Whereas codeine is converted to morphine via CYP2D6, that is the cytochrome P450 metabolism pathway. So any rapid metabolism cause increased toxicity if they're using codeine. Next, if they misuse the routes and the overdoses. Suppose they're having insufflation or injection of tablets, heating of the fentanyl patches, or wearing multiple patches, these all will dramatically alter the absorption. So if there's a severe overdose, enzyme saturation increases severity, delays onset, and prolongs duration of toxicity. Next, let's talk about the opioid toxidrome. What is a classic opioid toxidrome? As everyone knows, it's a triad. The triad consists of meiosis, which is the pinpoint pupils, and there will be lethargy in the patients. As we can see, the patient will be somnolent, ranging from somnolence to coma. And also the patient will be having the respiratory depression, which will be shown by clinically. He'll be having slow and shallow breathing. So this progressive respiratory depression will lead to hypercarbia, hypoxia, and cyanosis. This is the primary cause of morbidity and mortality in opioid intoxication. Next, what about the other clinical features? That means other different systems. Regarding the cardiovascular, it can cause orthostatic hypotension because of the vasodilator effect. Next, it can cause nausea, vomiting, which is especially in patients who are having opioid naive. That means who have not been exposed to regular exposure of opioid. In those patients, usually vomiting or nausea will be seen, and ileus can be seen because of reduced gastric motility, and there can be urinary retention. And also, these opioid drugs will have histamine release, hence causing localized urticaria and bronchospasm from the mast cell activation. Next comes the serious complications. There can be hypothermia, rhabdomyolysis, compartment syndrome, and myoglobinuric renal failure, all complication each leading to the other. And you need to understand that specific to tramadol and meperidine overdoses, the complication intoxication causes seizures. So only tramadol and meperidine can cause seizures. It's not common to every other opioid. Next, let's talk about the eye changes in the opioid toxicity. As you have described in the clinical triad, opioid poisoning will always cause pinpoint pupils, which is a classical finding. But you should be also aware that it is not always that the patient should have a pinpoint pupil. There can be normal or dilated pupils, but these both will not exclude the opioid overdose. First exception is if the patient is having uh, a patient can have large pupil, that is mydriasis, case of pentagocin and meperidine. And also, if the patient has severe cerebral hypoxia, then again mydriasis can be seen. And also, you should always remember that the toxicology patients always come with co-ingestants. So if the patient is co-ingested as scopolamine or diphenoxylate, then again mydriasis can be seen. So we should never solely rely on pupil size. Should always consider mixed ingestions. And also the three conditions where mydriasis can be seen in a opioid poisoning will be if there is a pentagocin or meperidine, or severe cerebral hypoxia, or if it's co-ingestions. Next, a specific pathophysiology of opioid will be an acute lung injury. Previously, it was termed as non-cardiogenic pulmonary edema. This lung injury is so uncommon, and also it causes severe complication of opioid overdose. It occurs in 10% of severe cases and it requires naloxone. So what are the features? As the name suggests, non-cardiogenic pulmonary edema. So the patient will be having tachypnea, there can be Krebs heard, and hence the saturation will be dropping. On a typical chest X-ray, you'll have a bilateral infiltrates, but more importantly, we'll have a normal cardiac silhouette. So this normal cardiac silhouette will identify that it might be probably a non-cardiogenic cause. And further, you can obviously do a various ultrasounding focus findings to be seen. Next, what about the onset? The acute lung injury onset will be usually immediate or it can be delayed up to 24 hours. So what do you do? What is the management in such case? First thing, as usual, as the patient will be having reduced oxygen saturation, you start with oxygen supplementation. And as we know, understand the pathophysiology of pulmonary edema, we can better aid or help with non-invasive or invasive ventilatory support. But more importantly, you need to understand that giving an additional naloxone as other than the standard dosing, or giving diuretics or adding digoxin, these all other treatment not required in this condition. So here we need to just supplement oxygen with the help of non-invasive or invasive ventilatory support. That is the primary treatment, and this onset would be immediate, or within the 24 hours it will be seen. As to explain the pathophysiology, it is actually multifactorial. It might be because of the hypoxia, or maybe the histamine release, or negative pressure lung injury, or some other neurogenic mechanisms causing this acute lung injury. Next, some other pathophysiology which is here is serotonin syndrome and opioids. So there are few trigger opioids when mixed with the co-medication can cause serotonin syndrome. The trigger opioids are meperidine, tramadol, and dextromethorphan. So when these are combined with MAO inhibitors, SSRIs, or linezolid, that's when we can see the serotonin syndrome. The key features of serotonin syndrome, the CNS symptoms would be ranging from anxiety to delirium. And in regarding the autonomic features, there can be hyperthermia and instability too. And regarding the neuromuscular, this is a key feature for the serotonin syndrome. It's a hyperreflexia. More importantly, the hyperreflexia and this lower limb rigidity helps us to identify the serotonin syndrome. Now, the critical point here to note is naloxone will not reverse the serotonin syndrome, because the serotonin syndrome mechanism is because of excessive serotonin and not the mu receptor activation. So in serotonin syndrome, which is being developed in co-ingestion of opioids and the trigger co-medications, there is no role of naloxone as the treatment. Next, let us come to diagnosing this opioid overdose. When we have to diagnose the opioid overdose, the pre-hospital criteria is respiratory rate less than 12 per minute and meiosis. So these both combined with the circumstantial evidence, like what are the circumstantial evidence can be drug paraphernalia, the needle marks, the tourniquet, and the bystander corroboration. These all are the pre-hospital criteria to consider a opioid overdose. And there is a checklist to do the physical examination. Any patient coming with an opioid overdose, we should fully undress because they can have syringes which may be hidden in clothing. And we need to search for the injection sites and also see if they're using any fentanyl patches. And we need to even search for concealed opioids, even including the mucous cavities. And we can auscultate for the pulmonary edema, palpate muscle groups for compartment syndrome. Next, what are the differential diagnoses for opioid toxicity? So this we need to consider all the toxidromes and metabolic conditions which are mimicking the opioid overdose. Importantly, the having meiosis and CNS depression. So these both features which are having that are our differential diagnosis. One is a clonidine toxicity. Clonidine will be also having apnea, but the apnea will be response to stimulation, and patient will be having bradycardia and hypotension categorically in clonidine. Next, regarding the OP poisonings, the OP poisoning will have cholinergic toxicity specifically, but it can also have meiosis. So we need to differentiate from OP poisoning with the help of fasciculations and the other cholinergic toxidrome, which is vomiting, diarrhea, and sweatings. Next, some antipsychotics like phenothiazines, olanzapine, and risperidone can also cause CNS depression and meiosis via reducing the adrenergic tone. So this is also a differential diagnosis. Next differential diagnosis is gamma hydroxybutyrate sedatives. That is a hypnotics. These sedatives or hypnotics will cause profound CNS depression and sometimes can cause meiosis, which will put us in the differential diagnosis. But the classic benzodiazepines and barbiturates can cause depressions, but they'll not have meiosis, which will help us to differentiate from opioid toxicity. The rest, normal general metabolic conditions, which also can mimic the opioid toxicity, can be hypoglycemia, hypoxia, CNS infection, post-ictal state, and importantly, pontine hemorrhages can be the differential diagnosis for the opioid toxicity. Next, let us talk about how can we screen. So opioid toxicology screening is majorly done by an urine immunoassay. The most urine screens are able to detect morphine and even codeine and heroin majorly. Somewhat of hydromorphine because it's a metabolized to morphine. But there are specifically immunoassays which exist for oxycodone, fentanyl, and methadone. So this is not the general urine immunoassay. They have specific immunoassays for these three other compounds. Next, to always confirm a positive immunoassay, we need to use a gas chromatography or mass spectroscopy testing. Regarding the detection windows, regarding the detection windows, we need to take even serum acetaminophen because usually the opioid and acetaminophen formulation comes in combination. So we can even use the serum acetaminophen levels also have to be seen. And regarding the testing, codeine, morphine, and heroin urine tests will be positive 2 to 4 days even after single use. Whereas oxycodone, fentanyl, and methadone urine assays, these specific assays will stay positive up to 3 days. Next, let's start with the treatment. First, any treatment of toxicology, we need to talk about the decontamination. In decontamination, specifically gastrointestinal decontamination, here activated charcoal is useful, and this dosage will be as usual 1 gram per kg per oral. So we suggest activated charcoal only in selected cases. Majorly in pediatric oral injections is suggested, and also if the patient is fully awake or if the airway has been secured with endotracheal intubation, we can use the activated charcoal. And there is a role of multiple or delayed doses in conditions where there is diphenoxylate atropine overdoses. I'll be talking about this compound later. If suppose the case of diphenoxylate atropine, then we can have a multiple or delayed doses of GI decontamination, or if your patient has consumed sustained released opioid injections. Here, the opioid itself causes reduced GI motility, and that's why and being a sustained release, it will prolong the GI transit and the absorption time. So in such condition, multiple or delayed dose of activated charcoal will be useful. Next, as usual, the symptomatic treatment, the first emergency way, how we approach ABCDA. So regarding the airway and ventilation. So first, the patient, whenever we receive opioid toxicity, we are considering the patient have respiratory depression. So what do? We need to ensure that the ventilation is adequate. So we use bag and valve mask for ventilation. So we ensure that oxygenation with bag and valve mask. After ensuring that the ventilation is successful, that is when we give the antidote. The antidote is the naloxone. Suppose we are not able to secure the airway and ventilation is not adequate, then definitely we need to go ahead with the intubation. Because intubation can also provide us a different route for providing the naloxone. Now, what is naloxone? So the mechanism of naloxone is it's a competitive antagonist. The antagonism is at the mu receptor. So it reverses this respiratory depression, sedation, meiosis, and then the analgesia effects. And regarding the pharmacokinetics, the half-life is 60 to 90 minutes, but the duration will be as short as 20 minutes if there is a large opioid load. But there's a poor oral availability for the naloxone. That is the reason the routes which we select will be usually intranasal or inhalational route. Even IV subcutaneous IM can be given and intratracheal also can be given. Suppose you're using the nebulized form of naloxone. This nebulized form will be reversing the CNS or respiratory depression, and additional 10% might be requiring for the parenteral for rescuing through parenteral routes. Intranasal route is a route which is widely used by the EMS and bystander programs because when they arrive at the patient side, they can use it easily. And the oral availability, as I explained, is reduced. So these are the routes through which naloxone can be effectively delivered. Now, what is a dosing strategy? Let us consider three categories of patient. The first category is a patient who is opioid dependent. That means patient who is consuming opioid on regular basis, and the patient is in a modest depression. So in that patient, we'll start with a very mild dose, that is 0.04 mg IV, and we will be repeating this dose every 2 to 3 minutes till and unless the patient's vitals or the hemodynamic stability is achieved. So we'll repeat the dose of 0.04 to zero point 0.4 mg every 2 to 3 minutes. Now let us go to the second category. These are the non-dependent. That means these are not regularly using the opioids. And the same when the patient is in modest depression. Here the dosing will be at the higher level, that is 0.4 mg IV. And again, repeat doses can be 0.04 to 0.4 mg and every 2 to 3 minutes. So the reason why in the opioid dependent, we start with a very low doses. If we use a higher dose of naloxone, because the patient is already opioid dependent, we can push the patient to the acute withdrawal. So higher doses will risk precipitating acute withdrawal in the opioid dependent patients. Whereas in non-dependent patients, as withdrawal is not the primary withdrawal will not be the primary problem. Here we can go with a higher dose of 0.4 mg, and we can do incremental dosing. We should not give a suddenly higher dose because a higher dose again will push towards withdrawal. Now let us come to the third situation where we have a patient who is in apnea, or the patient is in near apnea with cyanosis. Here, very high dose of 2 mg IV is given, irrespective the patient is an opioid dependent or non-dependent. Here we can repeat every 2 mg every 3 minutes till maximum of 10 mg or till the respiratory depression resolves. Also, you need to remember that in special cases like fentanyl and the newer synthetic opioids or sustained release formulations or the patients who are body packers, they require higher than ordinary total naloxone doses. So just to summarize, we have three different separate conditions where we start using naloxone. One is the opioid dependent, which has modest depression, and opioid non-dependent with modest depression. In opioid dependent, we start with 0.04 mg, whereas opioid non-dependent, we start with 0.4 mg. Whereas if you find the patient apneic or near apnea, we directly give it a dose of 2 mg, and maximum dosing we can go is till 10 mg. And this is all for the normal morphine, these things. But if there's special case of fentanyl or no newer synthetic opioids or sustained release or if they're body packers, then we need to go with higher dosing also. Next, what about the naloxone infusion? So we consider using naloxone infusion when we are when we have to give the opioid duration which is exceeding. So like buprenorphine, methadone, or sustained release, and this transdermal fentanyl injections. In these cases, we can consider using naloxone infusion. And the rate at which we start is the 2/3 of the effective wake-up dose per hour IV. Same like as you learned in the OP poisoning. I think in OP poisoning, as you learned, you add up the atropine dose and you give 20 to 30% of it. Same like that, in this naloxone infusion, we give 2/3 of the total dose which was used to wake up the patient. And we use in specifically for these opioid drugs which patients use, if it's buprenorphine, methadone, or the sustained release or transdermal fentanyl injections. And after once we start the infusion, we need to admit the patient to a monitored unit. What about naloxone? Naloxone has usually no adverse effects, but in suspected overdose patients, suppose as we increase the dose of naloxone, there can be withdrawal effects. So these withdrawal effects will be the adverse effects. What are the withdrawal effects? It can be like anxiety, nausea, vomiting, diarrhea, abdominal cramps. We'll further discuss the withdrawal separate section. So there are a few other antagonists other than naloxones which can be used, which are naltrexone and nalmefene. Naltrexone is an oral composition which is used for abstinence post-detox. So once the patient has been undergone detox, to maintain the abstinence, we can use naltrexone. And it can also be given as IV, which is a monthly ER injection. So monthly once, that's enough. It is used to treat alcohol or opioid abstinence. Whereas nalmefene is an oral or parenteral drug, which is a very long-acting drug, and it's mostly available in Europe and not in US. Next, let's talk about how we dispose and follow up these cases. So once we get the opioid overdose patients, if suppose it is a heroine which is responding to naloxone, so we can safely discharge after 1 hour if this normal vitals and mental status is and patient is able to mobilize. So second pathway is the other opioids other than heroin. Usually other opioids other than heroin, it's better to observe 4 to 6 hours after the last naloxone dose. So post the patient again gets normal vitals and mental status, 4 to 6 hours of observation is required for other opioids other than heroin. And for the opioids which are long acting, it will require observation of at least 8 hours. So if the patient is having moderate to severe kind of symptoms, then it is better to admit in the monitored unit and we have to continue with the naloxone. And additionally, if the patient is having any suicidal intent, we need to add behavioral health evaluation and psychiatric consultation too. Now we'll talk about few specific opioids, just a short summaries of few opioids which can be asked as a short mark, 2 mark or 3 mark questions. So let's start with buprenorphine. Buprenorphine is a partial mu agonist which has a unique receptor kinetics. It is capable of both inducing and also treating opioid withdrawal. We should know in which clinical context we can use the buprenorphine. So what about the mechanism? As explained, buprenorphine is a mu agonist, which is a partial agonist, and kappa and delta antagonist. So because it has a decreased intrinsic mu activity, there will be a plateau effect at higher doses. So if we are having a buprenorphine toxicity, the effects at the higher doses will be same as the maximum range because it will show a plateau effect. And because it has high mu affinity and a slow dissociation, the duration of action is very long for buprenorphine. And buprenorphine has a poor oral bioavailability because of extensive first pass metabolism. So the way the buprenorphine is formulated is usually sublingual films or tablets or parenteral formulation. So oral buprenorphine is not usually available. And the way the buprenorphine is formulated, usually buprenorphine is combined with naloxone in 4:1 ratio when given sublingual, because naloxone usually has poor sublingual bioavailability, and it will avoid the combination of buprenorphine and this naloxone. It will avoid the opioid drug abusers to use buprenorphine as IV abuse because we combine it with naloxone in sublingual formation. In sublingual formation, naloxone does not have any bioavailability. But if suppose the person, drug abuser, uses this as an IV, naloxone as IV is potent and it will help to prevent buprenorphine toxicity. Next, now we need to understand three clinical scenarios. So depending on the clinical scenario, the action of buprenorphine matters. Suppose the patient is an opioid naive, that is, he is the first time taking any opioid. In that patient, when there's overdose, so already the CNS and respiratory depression happens and that plateaus because buprenorphine, as previously explained, is a partial mu agonist and it will plateau. So in these cases, a low dose naloxone will be incomplete. We need to use naloxone infusion. We need to admit the patient. So when there is an opioid overdose of buprenorphine, we need to have a naloxone infusion and admit. Now, the patient is an opioid abuser. In these cases, buprenorphine will precipitate withdrawal symptoms. And again, why it is? Because buprenorphine is a partial agonist. In presence of the complete agonists of the opioids, buprenorphine will, as it's a partial agonist, it will act as an antagonist and it will cause a withdrawal symptoms. So if the patient is dependent on full agonist, buprenorphine will precipitate withdrawal symptoms. So as everybody knows, management of withdrawal, we need to manage with antiemetics. And if the patient is having pain, then it's by non-opioid analgesics and non-benzo sedatives. Next, let's talk about the patient who is already in withdrawal. Here, when we give buprenorphine, it acts as a partial agonist and it will reduce the symptoms of the withdrawal. So it is useful as a bridge to medication-assisted treatment at discharge. So you need to understand the role of buprenorphine in three different clinical scenarios. If buprenorphine has been taken as overdose in a person who is not abusing the opioids, then we need to treat that person with low-dose naloxone as infusion and we need to admit the patient. And now if he's an abuser, if the patient is an abuser, buprenorphine will precipitate withdrawal and we need to manage withdrawal symptoms. And if the patient is already in withdrawal, then buprenorphine will help to alleviate the symptoms and reduce the withdrawal symptoms. So key concept is buprenorphine can both induce and treat the opioid withdrawal. So its timing of the clinical condition will determine which kind of effect it produces in the patient. Next drug is methadone. It's a synthetic opioid which has a prolonged kinetics. It is used in both opioid replacement therapy and also chronic pain management. So the major functioning of the methadone, the use of methadone is in the patients who have been advised for opioid replacement therapy, and also in patients who are having chronic pain management responding to opioids. But methadone has a significant side effects, which is cardiotoxic. So let's talk about the pharmacokinetics. Starts the initial analgesia starts within 8 to 12 hours, and half-life of drug is 12 to 18 hours. If you use repetitive dosing, then this half-life can extend up to 59 hours. So the advantage of this is we can have once daily dosing for the maintenance phase. So methadone's main role is in chronic analgesia, where we can use once a day dosing. Next, regarding the overdose, if suppose there's a methadone overdosing, it will be similar to the other opioids. But here, as we know, the half-life is prolonged. Here we'll have the dose effects, prolonged dose effects will be seen. And there's a higher overdose mortality because there will be usually co-ingestions. Here, in treatment of methadone overdose, we require naloxone infusion and definitely close neurorespiratory monitoring. As it's a long-acting duration, so infusion is advised. And methadone has drug interactions. Methadone's toxicity is increased whenever it's given along with antibiotics such as ciprofloxacin, fluconazole, ketoconazole, or omeprazole. Whereas withdrawal symptoms can be seen for a patient who is having methadone when given clarithromycin, phenobarbital, phenytoin, spironolactone, and verapamil. So whenever a patient is on methadone who has come to emergency room, always ask for the co-ingestant of the other drugs which have been initiated recently or just few days back, because these drug interactions specifically can push the patient into toxicity or withdrawal. And regarding the HIV medication, that's antiretroviral drugs, it can cause both toxicity and withdrawal. It's a complex interaction. So in regards to methadone, we should always remember that it is used in chronic replacement, that opioid replacement therapy and chronic pain management, and also it's drug interactions. Now, regarding the treatment, so methadone has cardiotoxicity by causing prolongation of QT interval. As the QT interval increases, you all might be aware that there's a risk of torsades pointes. So we require a ECG monitoring here. And regarding the treatment of the methadone, as per the cardiotoxicity, we treat it. So if the patient's QT prolongation is normal, and even the patient has an acute overdose, we'll just optimize the electrolytes and admit for a monitoring unit. But if the QTC is prolonged to 450 to 500 millisecond, in this range, we just correct the electrolytes and we repeat the ECGs and monitor the patient. But definitely, if the QTC is more than 500 milliseconds, we have to consider the methadone dose reduction or discontinuation of the drug. So this is the way we have to target treatment. Like suppose a patient is being given methadone for chronic analgesia. So on repeat follow-up, we need to get the ECGs. So depending on the QTC, we need to further reduce the dosing of methadone, or we need to correct the electrolytes. Next, other drug is the tramadol. This is a drug which is used frequently as a over-the-counter drug. So it's an analgesia with both noradrenergic and serotonergic mechanism of action. And its prodrug is an opioid activity. So the mechanism, it inhibits norepinephrine and serotonin reuptake. It directly has no effect on opioid binding initially, but when this tramadol is metabolized by the CYP enzymes, it causes a metabolite O-desmethyl tramadol. This O-desmethyl tramadol is an active metabolite which binds to mu receptors. And the effect of this CYP enzymes will vary with genetics, hepatic renal diseases. So the tramadol mechanism can vary the bioavailability and metabolism parameters. Next, what are the additional risks? Uh, Tramadol can cause higher hypoglycemic rates as compared to codeine in the first 30 days. Also, tramadol causes dependence and withdrawal with chronic use. Suppose there's an overdose toxicity of tramadol. What does it cause? The usual lethargy, nausea can be seen, but here specifically important point to be noticed, seizures. It will be usually single and anticonvulsants are rarely needed. So the important feature, clinical feature of tramadol toxicity is seizures. But if the dose is more than 500 mg, it can even cause coma, hypertension, respiratory depression, apnea, and even serotonin syndrome like features. You should be able to understand that naloxone has no role in preventing tramadol-induced seizures. Next, there are few words about mixed agonists and antagonists. Pentagocin, butorphanol, and nalbuphine are these category of drugs. So these receptor activity antagonist at mu receptor and agonist at kappa receptors. And these also can cause significant respiratory depression and overdose. Naloxone will reverse all these effects. So there's a withdrawal risk of this mixed agonist antagonist. They usually precipitate withdrawal in opioid dependent patients. And one important point about pentagocin, its overdose can additionally cause seizures. Next, earlier I was talking about a drug called diphenoxylate atropine overdose. To again remind you, this is the place where a multiple dosing of charcoal will be used. Basically, diphenoxylate atropine is a combination drug where diphenoxylate is 2.5 mg and atropine 0.025 mg. So it has two classification of drugs, that is opioid and anticholinergic drugs. So the toxidrome is biphasic. The first phase which the patient comes with is an anticholinergic, that is anti-muscarinic signs will be seen. And in phase 2, we'll see an opioid toxidrome. And regarding the management of this overdose, we have to differentiate depending on the age. If there's any children less than 6 years, they're usually symptomatic after a single tablet also. And the absorption will be delayed because atropine also causes reduced GI motility. So any children less than 6 years will be usually symptomatic and we need to admit for 24 hours observation. For the older children above 6 years and adults, we need to observe in ED for minimum of 6 hours. Activated charcoal is the main decontamination strategy unless contraindicated. Next, few words about the fentanyl and newer synthetic opioids. These are the major drivers of the overdose deaths as of now in the United States. It has 50 to 100 times the morphine potency, and greater than 50% overdose deaths are because of these drugs. And these drugs are usually illicitly manufactured, so they'll be having illicit components also present. And regarding the treatment, as high as 10 to 20 mg naloxone to the total dose. I mean, every 0.4 mg when we repeat the doses, as high as 10 to 22 mg can be required to reverse the respiratory depression. These examples of these dosings are fentanyl analogs, which is acetylfentanyl, butyryl furanyl fentanyl, and carfentanil, and even non-fentanyl mu agonists such as U477700. These drugs are the examples of this classification of novel synthetic opioids. These are having extreme potencies. As I explained, these are usually illicitly manufactured. So we'll have contaminants in the street opioids having benzodiazepines and also cocaine. So we'll be having unexpected toxicities. Different toxidromes the patient can be presented with. Let's talk about mixed drugs and adulterants. So heroin is usually whenever abused by the drug abusers, they can be having adulterants such as scopolamine. So we'll be having an anticholinergic toxidrome or meperidine. Meperidine adulterant usually causes irreversible Parkinsonism. And few other adulterant is clenbuterol. It's a long-acting beta agonist, usually a component of veterinary drugs, and it can cause cardiovascular effects. The other adulterants can be strychnine, quinine, and lactose or talc. Next, let's talk about what is crocodile. It's a desmorphine. It's a crude IV preparation which is synthesized from the codeine tablets. Here, there will be high concentration of tissue toxic impurities during the synthesis process. It is usually documented in Russia, and the major feature is the severe gangrene, tissue necrosis, and death at the injection site. This word crocodile arises from the Russian word which is used to say the skin changes, that is severe gangrene at the site of the injection. So we need to be always aware that whenever a patient comes with opioid toxicity, there can be these adulterants which will cause different types of toxidromes. So it will not be a single toxidrome with which the patient arrives. Next, few other words. There's a thing called cractum. Cractum, there's a principal alkaloid is mitragynine. It is a medicinally available used in Asia and South African Asia. Next is a krypton. Krypton is a combination of kratom plus O-desmethyl tramadol, which is a metabolite of the tramadol, along with caffeine. This is also seen in multiple fatalities due to synergistic opioid toxicity. These are the few combination with the opioids. Next, majority everybody knows about this loperamide. This is a it's called poor man's methadone. Regarding the toxicity profile, it it produces toxicity at dose of 50 to 300 mg, which is like 20 to 150 times the therapeutic dose. The usual therapeutic dose is 2 mg, so 20 times to 150 times if you consume, that is when the toxicity can be seen. It causes severe cardiotoxicity via sodium and potassium channel blockade. So where the cardiotoxicity will be present with QTC prolongation, causing QRS widening, can also cause ventricular tachycardia, ventricular fibrillation. And the management would be, as previously said, first will be the GI decontamination with activated charcoal. We can even repeat doses of activated charcoal because loperamide inhibits peristalsis and it will be available in the, it will be taking longer time for absorption. And if the patient presents with respiratory depression, then naloxone can be used. And if suppose the patient has cardiac toxicity, then soda bicarb 1 to 2 milli equivalents per kg per IV have to be used along with replacing the electrolytes. Whenever you receive white QRS, always correct the electrolytes first. And if suppose there is torcidus pointus, then we can do pacing or isoproterenol with 2 to 10 micrograms per minute IV. And also we can consider ECMO as the treatment. Now let us come to the next topic, which is opioid withdrawal. Till now, we have discussed all about the toxicity symptoms. Now we are talking about withdrawal, where the receptor activation will reduce. So what is the pathophysiology? So when there's even an abrupt cessation, so when the patient is abusing this drug, there will be down regulation of the receptors. So when there's an abrupt reception, there will be no time for receptor upregulation. So because of this no time for upregulation, there will be increased neuronal firing, and that will cause the withdrawal symptoms. Also, if you use antagonist at the receptors, that also will precipitate withdrawal. It can be precipitated by naloxone, naltrexone, even buprenorphine, as previously explained regarding the buprenorphine. Now, we have something called a COWS scale. It is a clinical opiate withdrawal scale. It consists of 11 symptoms. We assess the severity, and with the help of this scale, we can guide the initiation of buprenorphine or methadone, and also to monitor the treatment response. So regarding the clinical features of opioid withdrawal, the initial features of withdrawal usually starts slowly within the 3 days. And after 3 days, the peak will be there and slowly will resolve within 5 to 6 days. So what are the peak effects which suggest initial features, which is anxiety, the craving for the drug, lacrimation, rhinorrhea, diaphoresis, and yawning. These all suggest the initial features. And the additional features after the 12 hours of the onset, that is after 3 days, will be tremors, piloerection, and mydriasis. And subsequent features after long lasting till 5 days would be insomnia, muscle spasms, and abdominal pain. So you need to understand this is like a graph. Until 3 days, slowly the symptoms settle in, and 3 to 5 days is where there will be acute symptoms. After 5 days, slowly the patient gets better. Opioid withdrawal is very uncomfortable, but it is definitely not fatal. So these symptoms will not kill the patient, but they are very uncomfortable. But these symptoms can cause the patient sick, because, like as we can see, patient can develop aspiration from vomiting, causing pneumonitis, or can even make the patient dehydrated, and these will cause further complications. Now, how do we treat this withdrawal? If the patient is having only mild symptoms, we can give supportive symptomatic therapy like antiemetics or antidiarrheals. But if patient is having moderate withdrawal, then we have to use clonidine now. And if patient is having severe withdrawal, then we need to use opioid replacements like buprenorphine or methadone now. So as per the COW score, it will help us to guide this severity and also the treatment. Is it, are we getting the proper treatment response? Now, regarding the moderate withdrawal, we have something called as clonidine protocol. What is clonidine? Clonidine is a central alpha 2 agonist. This suppresses the noradrenergic hyperactivity, which is the driving force of the withdrawal symptoms. It does not prevent all these opioid withdrawal symptoms, but it just improves the tolerability. And important contraindication of the clonidine is if the patient is hypotensive or bradycardic, avoid clonidine. Now, regarding the dosing protocol, first we will give a test dose. A test dose of 75 to 100 microgram per oral is given. Then we reassess the BP and symptoms after 30 minutes. Suppose the patient's BP and symptoms are fine. The symptoms means the symptoms of withdrawal getting better and the BP has no fluctuations, not going to hypotension. Then we can initiate the clonidine. The initiation will be 150 microgram per oral, which we give in 3 doses for 3 days. After 3 days, we slowly discontinue by day 5, so that the symptom, as I was previously telling, the withdrawal symptoms usually last till 5 days. So by the 5th day, we can stop the taper and stop the clonidine, so the patient will not show any other withdrawal symptoms. Now, regarding in the severe opioid withdrawal, we talked about something called as opioid replacement. So the two drugs which can be given as opioid replacement is methadone and buprenorphine. Regarding methadone, for high dose users, we should which are not in maintenance programs, for them we can use this. So suppose a patient has come to your ED and is leaving, not admitting. So in that cases, methadone will be preferable. We can give 20 to 30 mg per oral at 10 mg IM. The methadone will suppress withdrawal without inducing euphoria. It will not trigger the euphoria component, just suppresses the withdrawal. Whereas buprenorphine is indicated for the medically ill or hospitalized patients in withdrawal. And the dosing is 0.3 to 1.2 mg IM or IV every Q6 hourly, or 2 to 4 mg sublingual every Q6 hourly. So regarding the opioid replacement therapy, the standard doses will be initiated and we need to titrate over 2 to 3 days because symptoms will be peaking and then tapering. So as I explained previously, withdrawal symptoms will usually peak by 3 days, last till 5 days and then reduce. So the same way, these both opioid replacement therapies, if initiated, should be tapered also. And detox during acute medical illness is usually unsuccessful. So what does it mean? Suppose a patient is abusing opioids and is admitted in our ED with some other medical illness. We can't expect to detox the patient. Just using the opioid replacement therapy, we can cause some symptom relief. And also an important point, never administer methadone or buprenorphine until withdrawal symptoms are present. So we should not use it to avoid precipitated, we should not use it like in front only to cause reduction of the withdrawal symptoms. We should always wait for the symptoms and then only start. Because if we give without the withdrawal symptoms, then we can precipitate withdrawal with the help of this opioid replacement therapy. Okay, so with this, we have completed the opioid toxicology. Next topic will be about the NSAID toxicology. So let's go ahead with the NSAID toxicology. So what makes this NSAID unique? So all NSAIDs will have a single primary mechanism, which is inhibition of the COX enzyme, that is cyclooxygenase. As the COX enzyme is inhibited, there will be reduced prostaglandin synthesis. If there is reduced prostaglandin synthesis, then there will be reduced that will produce antipyretic, analgesic, and anti-inflammatory effects. So you have to remember that NSAID toxicity is usually not so clinically seen, or it will not be more in the exams also we usually ask NSAID's adverse effects rather than NSAID toxicity, because adverse effects are more commonly prevalent. Now, again, detailing explaining the mechanism of action, this arachidonic acid, with the help of COX enzyme, is broken down into prostaglandins. These prostaglandins will cause the clinical effects. So these NSAIDs will reversibly inhibit the COX enzyme, hence by blocking conversion of arachidonic acid into prostaglandins. So the NSAIDs as drugs role as anti-inflammatory effect follows from reduced prostaglandin production, and because of reduced prostaglandin, there will be decreased neutrophil migration, and hence it is anti-inflammatory. Whereas antipyresis occurs via inhibition of PGE2 in the hypothalamus and thereby lowering the temperature set point. And analgesia is because of reduced prostaglandin mediated hyperalgesia at the peripheral pain fibers. So the NSAIDs has three important roles, which is anti-inflammatory, antipyretic, and analgesia. Constituently, all these three are mediated by the prostaglandins, that is reduced prostaglandins. Now, there are two types of COX, that is COX-1 and COX-2. So there are two types of COX. So then the laboratories also synthesize two types of NSAID, that is specific, COX-2 specific or non-specific NSAIDs. Where do we find the COX-1 enzyme? COX-1 enzyme is constitutive, that is baseline present in blood vessels, kidneys, and stomach. It is helpful in gastric cytoprotection and renal blood flow. So it is present in blood vessels, kidney, and stomach, and it is constitutively present. Whereas COX-2 is an inducible, that is, there will be a low basal levels and it will be upregulated when there are pro-inflammatory mediators. COX-2 is the one which drives pain and inflammation. So COX-2 is the enzyme which is the primarily which we have to target that therapeutically. The most NSAIDs which are available inhibit both these isoforms, that is COX-1 and COX-2, non-selectively. The unwanted GI toxicity, that is the side effects or adverse effects, is majorly because of the COX-1 inhibition. Because of COX-1 inhibition, it will strip away the gastric mucosal defense and cause all the GI symptoms. And COX-1 inhibition will cause loss of cytoprotective prostaglandins and hence cause GI toxicity. So remember, whenever they ask in Viva why it causes GI toxicity, you should always remember it's because of COX-1. Whereas the reason why we give NSAIDs for these patients therapeutically is to reduce the COX-2 activity. Now, regarding the COX selectivity and GI risks, there are two NSAIDs which preferentially inhibit COX-2, which are Etodolac and Meloxicam. Theoretically, they will be sparing the COX-1 and by reducing gastrointestinal harm. But what was seen is COX-2 selective agents are not more effective for analgesia or inflammation rather than non-specific NSAIDs, and still they cause significant GI effects. So whenever they ask if COX-2 inhibitors are free from GI toxicity, answer is no. Definitely, the pharmacological wise, we can see that NSAIDs which are specific to COX-2 should be having a GI safe option, but clinically, which is seen is they are not safe from GI toxicity, and also their activity, the effectivity for analgesia or inflammation is less as compared to non-specific NSAIDs. So the COX-2 specific NSAIDs clinically has no any added advantage. Now, what are the pharmacokinetics? NSAIDs are something which is rapid GI absorption and will reach peak serum values within 2 hours at therapeutic doses. And distribution, because NSAIDs are highly protein bound, it has low volume of distribution, and also it can cross blood-brain barrier. Regarding metabolism, it is primarily metabolized by liver. It has hepatic metabolism, and the half-life ranges from 2 hours, which is commonly seen in ibuprofen, to extended half-life of more than 50 hours seen in piroxicam. So by this, we can understand that if we want to give long-acting, then we have to go with piroxicam, and ibuprofen is a short-acting drug. So this long-acting, long half-life drug, we can produce prolonged toxicity in overdose. So whenever we want to dispose any person who is having an long-acting NSA toxicity, we need to think about the half-life. Now, what is the kinetics? In large overdose ingestion, so when there's a ingestion of large of ibuprofen or naproxen, the absorption will slow and peak plasma levels will shift to 3 to 4 hours. It will not be like linear graph because the protein binding site saturates and dramatically increasing the free drug fraction in a non-linear fashion. So the receptors, the drug binding sites will saturate, and it will not be like a linear graph. It will be a non-linear graph. This non-linear dose toxicity relationship will explain why delayed symptom onset and prolonged observation is warranted after massive ingestion. So you should understand that it is not a linear kind of a relationship. Now, what about the topical NSAIDs? The absorption and distribution of topical NSAIDs can be achieved in therapeutic dosing in synovial fluid concentration. So diclofenac and ketoprofen are most commonly used as topical agents. But the best use case is in acute muscular injuries. So only in acute conditions they have a role. They are less effective for chronic conditions such as osteoarthritis. So other added advantage of topical NSAIDs is in elderly patients and those who are having high gastrointestinal cardiovascular risk. We can prefer using topical over oral formulation to minimize the systemic exposure. And topical NSAIDs are only best use cases only in acute conditions, not in chronic conditions. Now, The NSAIDs are notorious for having drug interactions. So we'll talk about various drug interactions. First thing is aspirin. So ibuprofen will competitively inhibit aspirin's access to platelet COX, thereby blocking the thromboxane pathway, and it will undermine the aspirin's cardioprotective action. So ibuprofen is a poor choice in patients on low dose aspirin for cardioprotection. So whenever the patient is already on aspirin, avoid giving ibuprofen, because ibuprofen will directly contradict the aspirin's cardioprotective activity. Whereas things to note here is ketorolac and diclofenac will not interfere with aspirin's antiplatelet activity. So if the patient is already having aspirin for cardioprotective effect, avoid ibuprofen and give ketorolac or diclofenac. Next, let's talk about the interaction with antihypertensive. So NSAIDs will reduce the effectiveness of antihypertensives because they inhibit the prostaglandin synthesis in the kidney. So there will be inhibition of prostaglandin synthesis, and it will cause vasodilation and natriuresis in the kidney. So this renal prostaglandin inhibition will cause sodium and water retention, and there will be renal vasoconstriction, and there will be reduced GFR. So the net effect will be causing elevated blood pressure, and even it will cause worsening of the treated hypertension. So because these NSAIDs will trouble the kidney, at the kidney level, the prostaglandin pathway, there is an antihypertensive interaction. It is not directly stopping the drug growth. Next interaction, let's talk about warfarin or newer oral anticoagulants. The NSAIDs, when combined with this anticoagulants, will cause a high risk of upper GI bleeding. Specifically, the NSAID, meloxicam, is the only NSAID which is consistently shown to raise INR when used along with warfarin. So whenever we use COX-2 inhibitors with warfarin, they also carry GI bleeding risk. It's not like COX-2 inhibitors will act on COX-2 and COX-2 is not present in GI, so it's not, but still we have clinically seen that it carries GI bleeding risk. Chronic NSAID patients should be avoided in anticoagulated patients. Next interaction, we'll talk about renally cleared drugs. As previously explained, because of NSAIDs, there will be reduced renal prostaglandins and it causes reduced GFR. So here the renally cleared drugs such as lithium, methotrexate, and metformin, these all can go into toxicities. So which drugs increase in concentration with NSAIDs? When this question is asked, you should always answer the drugs which are renally cleared. Examples are lithium, methotrexate, and metformin. So with the association with lactic acidosis can be seen in metformin levels. Next, regarding the safety profile, at therapeutic doses, NSAIDs are generally safe, but definitely they have a well-documented side effects if they're being chronically used. Next, regarding the higher side effect burden, indomethacin, piroxicam, and diclofenac are the three majorly which account for disproportionate share of NSAID-related adverse events. And regarding the favorable profile, ibuprofen, which is a propionic acid class, this has a fewer adverse effects. So that is why it is widespread and it is available over the counter and can be preferably used in pediatric and general practice settings. So the NSAID, which can be given without any consideration, is ibuprofen. And if you are giving diclofenac, indomethacin, or piroxicam, these are the ones which can cause higher side effects. Now let us discuss the side effects or adverse effects of NSAID system-wise. Regarding the CNS, it can cause acute psychosis. Key point is acute psychosis can be seen with indomethacin and selindac. These two NSAIDs usually can cause acute psychosis. It is attributed to the structural similarity with serotonin and more commonly seen in elderly patients. Second important CNS toxicity is NSAID-induced aseptic meningitis. As the word suggests, aseptic, not caused because of any infection, but NSAID. So it is usually presented, the presentation time is within hours, and the patient can come with fever, headache, neck stiffness, the triad of meningitis. But if you take the CSF sample, here we can see increased WBC, increased protein, and normal or decreased glucose, which all together fits the picture of meningitis. But only key diagnosis will be this meningitis will be resolved on drug withdrawal, and it can recur on rechallenging the drug. So this can confirm the hypersensitivity. And we need to know in which patients is this commonly seen. It is predominantly seen in patients with autoimmune diseases like SLE. And the agents which are implicated are ibuprofen, naproxen, diclofenac, and others. So we need to always exclude infectious meningitis first, and then we need to consider NSAIDs also causing aseptic meningitis. Next, let's talk about cardiovascular system, cardiovascular toxicity. So there will be cardiovascular toxicity means regarding the COX-2 inhibitors, which are the cyclox, because of the aspirin effect and all that. The greatest MI risk occurs in the first month of use of this NSAIDs. And that's the reason whenever you want to give pain medication for this kind of high-risk patients, start with acetaminophen. And if the patient is more than 75 years, as previously explained, prefer topical over oral NSAIDs. Suppose if you have to give the NSAIDs, it's necessary, then we always have to select shortest course and lowest effective dose, because the greatest risk factors is higher dose will cause higher risk, and longer duration will cause greater risk. And timing also, the greatest MI risk is within the first 1 month. So who are the patients which are having high risk, which are having established CAD? This is also high risk. And non-selective NSAIDs and even COX-2 also both have increased risk only. Next, regarding the pulmonary toxicity, bronchospasm in asthmatics can be seen. Just like aspirin exacerbated respiratory disease, even NSAIDs can also exacerbate bronchospasm in asthmatics. And the spectrum ranges from normal rhinitis to severe bronchospasm with laryngeal edema. So the basic mechanism to explain the pulmonary effects is there can be increased systemic leukotrienes because there is this reduced prostaglandins like PGE2 via COX-1 inhibition. There will be increased systemic leukotrienes, and these will push the patient into the spectrum of rhinitis to severe bronchospasm. Some other rare pulmonary toxicities are hypersensitive pneumonitis, eosinophilic pneumonia, and pulmonary edema. And regarding the gastrointestinal effects, this is the most common adverse effect of the NSAIDs. So the most common symptoms which are dyspepsia, heartburn, nausea, and the most severe complication being GI bleeding. So what is the mechanism? So because of this NSAIDs, there will be reduced cytoprotective prostaglandins, and hence there is reduced mucus at the bicarbonate, and there is mucosal breakdown, causing further forming ulcers and then GI bleeds. So the injury ranges from the mild ulceration to life-threatening hemorrhage. Now let's talk about hepatic adverse effects. This specifically diclofenac and sulindac are the most commonly implicated in NSAID hepatotoxicity. So the presenting features will be usually cholestasis and elevated transaminases, as we can see in the LFTs. Further, drug withdrawal can also lead to complete recovery. So once this insulting drugs, if you stop the hepatic toxicity or hepatic side effects will be recovered. Next, regarding the renal, previously we have already discussed this COX inhibition will reduce the renal prostaglandin and cause renal vasoconstriction, decrease the GFR. So if we are continuously a long duration time of NSAIDs use will cause acute tubular necrosis, interstitial nephritis, or glomerular injury. Next, talking about the hematologic toxicity. So that as the role of action of NSAIDs, it inhibits the platelet thrombox and A2 synthesis. Therefore, it causes prolonged bleeding time. So COX-2 inhibitors will spare the platelet COX-1 and have minimal antiplatelet effect. So only specific role of COX-2 is in antiplatelet effect. Other than that, COX-2 inhibitors will also be as par with the non-specific NSAIDs in every other side effect or the way of mechanism. Only in this scenario of antiplatelet effect, where a COX-2 has minimal antiplatelet effect. So clinically significant bleeding at standard doses is uncommon. There are few rare but serious complications of hematology, which are bone marrow suppression and aplastic anemia. Indomethacin, diclofenac account for most of these cases. Also, rare diseases like TTP, agranulocytosis, hemolytic anemia can also be seen. Next, coming to dermatological toxicity. So here there is a spectrum of reaction that can be having just like a simple hypersensitivity reaction to ranging like SJS and TN. The most implicated NSAIDs are phenylbutazone and piroxicam. This both oral and topical NSAIDs will cause photosensitivity, whereas ketoprofen and piroxicam are linked to photoallergic reactions. So there is something called photosensitivity and also something as photoallergic reaction. Piroxicam causes both. The mild symptoms are urticaria, angioedema, and maculopapular rash, whereas severe toxicity causes SJS and TEN. So regarding TEN can be caused by drug related. So one third of the drug related causing TEN cases is because of NSAIDs. So NSAIDs is notorious to cause TEN. And regarding bone and fracture healing, so there's a theoretical concern that the prostaglandins play a role in bone remodeling. So if you use COX inhibiting drugs such as NSAIDs, then it will impair the fracture healing. But the current evidence and guidelines clearly say that NSAIDs are not contraindicated in fracture patients based on current evidence, despite the theoretical concerns. So to summarize, we have discussed about the CNS. Most important in CNS is the psychosis of indomethacin and aseptic meningitis. NSAIDs induced aseptic meningitis. Regarding the cardiovascular, the increased MI risk and hypertension. And regarding the pulmonary, the bronchospasms. And regarding GI, it causes ulcer, bleeding, dyspepsia. And hepatic, we understood that diclofenac is one of the most common notorious agent, causing because it's metabolized by hepatic metabolism, it can cause the cholestasis and transaminases. And regarding the renal, tubular necrosis, interstitial nephritis is the most common seen. And regarding the hematologic, the antiplatelet function will be there, but COX-2 will not be causing antiplatelet. And regarding the dermatologic symptoms, it ranges from urticaria to SJS or TEN. So NSAIDs will affect virtually every major organ system. So systemic toxicity is most prominent with chronic use rather than acute overdose. So always you need to consider patients' comorbidities while selecting a particularly specific NSAID. There's another reproductive toxicity of NSAIDs. So basically, prostaglandins are highly concentrated in uterus at term, and at these prostaglandins are essential for stimulating normal level. Suppose the pregnant female takes NSAIDs at this point of time, it will reduce this prostaglandin and impair the uterine motility and can also cause miscarriage. So there's another role of NSAIDs. NSAIDs can cause premature constriction of the ductus arteriosus, leading to fetal pulmonary hypertension. So it is a serious and potentially irreversible complication. So a key cutoff that is we should be avoiding NSAIDs preferably in a pregnant female, but NSAID causing miscarriage. To avoid this, a key cutoff is 29 weeks of gestation. Should remember that post 29 weeks, avoid prescribing NSAIDs to a pregnant female. So regarding the overdose, till now we have read all the side effects. Majorly, all were because of chronic usage. These are the side effects. Now we are talking about the overdose. So regarding ibuprofen specifically, an ingestion above 100 mg per kg threshold will cause mild symptoms. So the threshold is 100 mg per kg, and above 400 mg per kg is the place where we can expect severe toxicity. What are the toxic symptoms? Apnea, coma, metabolic acidosis will be usually seen. And the most common agent of NSAID overdose is the ibuprofen, which is because it's mostly available over the counter drug. So you need to remember importantly in exam, if it is less than 100 mg per kg, mostly it's unlikely toxic. But if the patient has consumed more than 400 mg per kg, then definitely you need to expect significant risk of severe manifestations. Again, system-wise describing, it is the same as the side effects as we have described, but at the higher level. The key important point in CNS, if the NSAID is mefenamic acid, it can cause seizures. And treatment of these seizures is by IV benzodiazepines. Regarding cardiovascular, bradycardia and arrhythmias resulting into VT, VF can also be seen. But NSAIDs are not primarily dysarthmogenic. Arrhythmias are mainly because of the electrolyte fluid disturbances, meaning this NSAID, because of this renal involvement, it can cause electrolyte disturbances, and these electrolyte disturbances causing the cardiovascular arrhythmias. So this is the pathophysiology. And regarding the renal, the AK will be seen, hematuria and oliguria can be seen. And mostly it is a reversible pattern of renal damage. Once the toxicity dose has been treated or symptomatically managed, usually the renal capacity will also reverse and may require a long-term dialysis if it is severe. Next, regarding GI and hepatic toxicity in overdose. Regarding the GI manifestations, abdominal pain, nausea, and vomiting are the most common symptoms. And life-threatening GI hemorrhage is uncommon in acute overdose versus chronic use. So The GI hemorrhage is usually seen in chronic overuse of NSAIDs rather than an acute overdose. And regarding hepatic and pancreatic toxicity, cholestasis and transaminases can be seen, but pancreatitis is rarely documented with ibuprofen and indomethacin. So pancreatitis can be also been seen in acute overdose. So regarding the management, so first we need to calculate the estimate dose, that is mg per kg, how much did the patient take. Then definitely, as every toxicology case, we need to screen for co-ingestions, that is acetaminophen and salicylates. Then also take 12 lead to assess the conduction in dysarrhythmias. Depending upon the estimated dose, we can stratify risk, that is less than 100 means non-toxic, above than 400 means high toxicity. So every time the management of toxicology starts with decontamination, so activated charcoal is recommended within 1 to 2 hours of ingestion with intact airway or normal mental status. Second, if the patient is requiring hemodynamic support, we start with IV fluids. And to give GI protection, we can use H2 blockers or PPI empirically to reduce the GI irritation and bleeding risk. And definitely these NSAIDs will cause renal disturbances and causing electrolyte disturbances. So always try to correct the electrolyte corrections. So we need to replace the potassium and bicarbonate as needed. And if the patient is having seizures, IV benzodiazepine are first line of management. And special decontamination, we can consider gastric lavage if we are using the drug of mefenamic acid or phenylbutazone, because these are long acting, so gastric lavage will be helpful. And even whole bowel irrigation can be advised if these are enteric coated formulation with delayed absorption. Next, important role question here in NSAID toxicity is dialysis. Is dialysis useful or not? Dialysis is not useful for NSAID removal because NSAIDs are highly protein binding and hemodialysis ineffective. They're even hemofiltration also ineffective, hemoperfusion ineffective, and even alkalization of urine is also ineffective in NSAIDs. But definitely, dialysis is indicated in such conditions where there is refractory metabolic acidosis or if there is severe electrolyte disturbances and patient went into acute AKI renal failure. So dialysis is not useful for the NSAID removal. Dialysis is useful for only supportive care. Next, regarding the investigation, general metabolic profiles, that is serum chemistry panel of electrolytes, renal profile, hepatic profile, everything is required. And here, keynote important is serum NSAID level is not useful because it does not correlate with the toxicity. For other injections like opioid or even paracetamol, acetaminophen, we take serum levels. But in NSAIDs toxicity, serum NSAID level is not useful. And regarding the disposition, we need to discharge patient after 4 hours of observation if vitals are normal. But if the patient has presented with altered mental state or abnormal vitals, then we need to admit. Usually the prognosis of an NSAID toxicity is generally good. If they can survive, if they have survived the initial insult. Regarding the basically NSAID overdose, first we see if the patient is symptomatic or not. Symptomatic means whether having altered mental status, seizures, or abdominal. If it is S, then we do the simple ABCD emergency pathway of getting definitive airway management. If the patient is hypotensive, we give it fluids or support with vasopressors. And if there are seizures, then IV benzodiazepine is the choice. If there is patient is not symptomatic, then we identify the quantity and type of NSAID ingested. We go with decontamination using the activated charcoal and check the electrolytes and other co-ingestions. And if it is vitals are all stable, we'll observe for 4 hours. If still there are a few symptoms, then we will admit. If there are no symptoms, then medically we can discharge along with psychiatric consultation. So yeah, that ends the class on the opioid and NSAID toxicity. Majorly, I have discussed as per whatever is there in Tintinelli. So I think this can help you guide for your exam preparation per se. And I try to cover all the basics required in the management of opioid and NSAID toxicity. So yeah, thank you for all of you attending the class. Srijit?
Thank you so much, Naveen. It was a very long lecture, and you wonderfully covered all the topics.
Okay.
And even though we were using it on a daily basis, NSAIDs and opioids, so much of detail, so much of pharmacology, so much of drug interaction, I think everybody would have gotten an idea by now with your lecture. And thank you so much for joining on such short notice, Naveen. Hoping to see you again soon.
Okay, thank you for everyone attending the lecture, and also sorry that it has been such a boring topic. Toxicology is usually boring. Okay,
No, you managed it very well. Thank you. Thank you so much.
okay, thank you then.
Thank you, everyone. Thank you, everyone, for joining. We will be back with another session in a couple of days. Thank you.